Moving us through our agenda, we're starting off with Neil, and Neil's going to talk about the evolving and growing pediatric complex care program.
We've got pamphlets and such. So most of you have already attended one of our preliminary, what would you like to see if we could create a complex care center? And what would that look like? And I can happily say we've done it. And we're now coming to you because we're actually ready to expand it out into any of the private practices as well. So originally we kind of said, let's just get this started with the kids from AC6 that we already know, and let's make sure we can make this actually happen. And then of course, it's a very small team. So 5 people. The director has been changed already. The office manager's been changed already. The care coordinator has been changed already. Amanda Savona went out on maternity leave for 4 months and just came back this week. And I went out for a month of surgery in January. So small team that we haven't expanded until now because we just needed to keep going. So we're back. Whole team's ready to go. Everybody's been set, replaced. So what we're trying to do is really focus in on that top 1% of complex kids. So the kids that are on vents, home feedings, G-tubes, has 5 subspecialists, has home nursing, the families that drive you absolutely crazy with the day-to-day management. We are happy to help with the management, but I do not want to take over as primary care for those kids. So unlike the adult primary care clinic where they're the PCP, I just want to be supportive and helpful and put the team together to do some of the paperwork, to do some of the daily phone calls, to make the quick access to get into Pan's clinic, because that's really who needs to answer the question, or they need to get their J-tube changed, but that's always a hassle of going through the ED. Can we streamline some of that with the ultimate goal of keeping our complex kids out of the ED, because we all know what happens when they show up there, they get admitted, and hopefully shorten any hospital stays that they do have to get them in and out a little bit faster so that we can help manage that a little bit. So we've got 129 kids in the program currently. A little bit of early data that LJ's been able to pull out of AHP for only 26 kids. We saved $1 million already. So again, how do we do that? We do all kinds of things from telemedicine and at home, and even including starting their IV antibiotics. I mean, these kids all have nerves. So it's not like you can't continue their care. You don't need to bring them into the hospital necessarily, but when we do, we do. So again, a bad weekend, 3 of my kids ended up in the ICU this weekend. So blue team is taking over the PICU. You are trying to get anybody in, my fault. But it's also getting the kids right back out again as soon as we can. So goal is to now give me your top 1% of kids that you've really, parents could use some closer nurse that's running our triage program as her cell phone is accepted. Parents, that's the biggest thing they complain about. When they call, they get the answering service or they get the queue for who's going to answer the call, and they have to go through who are you and what is your kid doing versus direct access to somebody that already knows their kids. We've already done the intake with them, and Heather can really cut to the chase about what do you need help with. Do you just need a shoulder to reassure you, or do you really need to get into whatever subspecialty? I'd love to try to get at least, and the other thing we're doing is every 6 months, we'll have a wraparound meeting with virtual, but with mom, with any of the caregivers that are important in kind of decision-making. So a little bit like the high-risk respiratory clinic has done with ENT, PANS, and pulmonary all sitting together. It's a much better experience for parents to be able to get their questions answered and not have ENT say one thing and PANS say the opposite. Pointing fingers no, it's a reflex problem. No, it's really not. That we're trying to avoid by having everybody at the same meeting or in every 6 months. And it also helps because so many of our kids, you only talk about their acute illness. No, we want to wrap around what else have we needed, what equipment needs. And we're getting really good about getting all the prior authorizations that you need for equipment, writing the orders for every 6 months. They have to get their CD pass paper. They need to get their home nursing authorizations. We can at least get that set up. I still haven't talked to Excelis yet to find out, can I just sign those? Or does it have to come from the PCP signing those? So right now,
I can do that.
we've been faxing them back out.
Yeah.
I'm happy to sign your name at the bottom of a paper that Heather prepares.
Thank you for your.
Yeah. So that's the goal. That's where we're headed. Ultimately, we expect to be up to about 400 kids in the program in the next year and a half. And I also just found out last week, I've been pushing telemedicine. ChildCare is like the #1 product for parents to be able to have a stethoscope, otoscope in the home. RGH has been starting with the ChildCare product for home use, and they got an exclusive contract up until last summer. So I got through to make them realize like that's not exclusive anymore. And we're gonna start handing out ChildCare units to our complex care kids at home, so parents can literally look in the ear, listen to the lungs, and transmit it to both us at complex care, but also eventually, if I get the right permission slips, all of you could log into ChildCare to listen to your kids whenever you want to.
Man, where was that 5 years ago?
Okay, when I had 2 kids on ventilators.
Yeah, it's been out there. I just haven't been able to get my hands on these units. So that's the goal. Is got one more program. So NICU grads. Anybody love to see their NICU grads after they've been in the NICU for 4 months? Parents are all settled in, happy, life is good.
They don't poop.
Yeah. We're gonna actually, all babies under 28 weeks, the NICU would like to do a discharge follow-up clinic. So they're committing a neonatologist to help with that transition as they go home. Like, its developmental assessment is in place. You can call the NICU, they're happy to answer your questions, but there's no real wraparound care. So our complex care center will enroll all of our 28-weekers and under to do that. Let's transition you home. Let's check in with their parents at 24 hours after they get home. Probably see the PCP right now, like the NICU insists, like must see them in 24 hours. Like they've been in the hospital 4 months. You don't need to be seen in 24 hours. So we're gonna try to make that like 3 to 4 days out to try to see whoever's in your practice that's actually gonna follow them rather than the person that has an opening on their schedule tomorrow. Makes a lot more sense.
And they all go home over the weekend.
Yes, they all do.
Or suddenly. And they need something on Monday.
Yep.
Yep.
So we'll be checking in, we'll coordinate the visits so that it's alternating. It's not gonna be, everybody's gonna see you tomorrow. It's like, we'll do a visit, PCP will do a visit, developmental neonatologist will do a visit at 7 days, the 2-week checkup, like, we'll decide who wants to do that. But then ultimately, our team will make sure they get in with all those subspecialists down the road. So Dennis Quo really wants to follow these kids all the way up until kindergarten for their developmentals. In his mindset, it's not just about school readiness and early intervention. It's the kids that, how do you recognize CP 9 months out? They're no longer hypotonic. They're starting to get a little bit hypertonic. Does that affect their feeding ability? So we sent them home with NG tubes. Who's making that determination when the kid's actually ready to start swallowing? Is that PANS clinic? Is that a developmental assessment? Is that primary care pediatrician? Right now, it's all been thrown back to the primary care pediatrician. We kind of like, let's try it and see what happens. And then we get overruled by PANS and they say, no, we're gonna go back to GQ. This will help coordinate all of that. So it's gonna be much more laid out and the parents will know who to call for what and how often they'll be checked in on. So that's starting probably June. We'll actually have that formalized for the kids. And we're not gonna ask the parents, do you wanna be in the complex care center? It's like, we're just gonna make this, if you're graduating from the NICU, here's what you can expect and here's what's gonna follow you and make that all happen in the next couple of months. So we've taken almost a year to have meetings to decide how many people need to be in this team. So we really narrowed it down to developmental peds, NICU, and then complex care. And then the other subspecialists will stay as they currently are.
I mean, hard to keep your numbers to 400, I would think.
About 80 NICU babies a year are coming out under 28 weeks. So we expect that most of those will follow for the year or two. But then many of them will be able to like graduate out of complex care because they're fine by the time they start feeding. So we won't keep them the whole 5 years. Dennis will have to keep them. Track them all the way up to school readiness. But we'll kind of take them in and out. And that's the other group. I think they'll use the ChildCare unit the most. And we'll show them how to use it before they even leave the NICU. If you haven't seen Title Care, you can go on their internet site, but it's really a little cube. It doesn't take up much room at all and it connects to your phone. So nothing that you have to install on your home computer. It's all Bluetooth and it just links to your phone and goes up to the cloud. So none of the information needs to be worried about where is it being stored. And then you as a provider would just go into titlecare.com, log in as a provider and pull up your patient. So look at their ears, nose, throat, whatever, and then also listen to their lungs. So I'm excited about the stethoscope part of it is the most. It's a whole $190 a year for a subscription. Like one ED visit will pay for their whole Title Care for the next 5 years. So, and LJ's gonna give me money, so. No, this is all part of like, if we can get to value-based payment like we were already supposed to be in, this would have been an easy value-based payment because we're gonna save insurance companies lots and lots of money on these kids. Not a hard business plan to make, and Tom Greenwood's already like, do what you need to do. If you can keep these kids out of the ED in the hospital, I'll buy the units. So he's buying the first 50 units just to get us going.
So Neil, how do you envision when you do the twice yearly visits, for example, will the PCP be invited to join in those virtually? So
Always invited. The timing is always the hardest part. So like kind of like
Yeah.
when's the best time to set these up? So we may want to adjust our times a little bit. So with Amanda being back now, we have more daytime coverage. But you know, if you say like, I can only do this at 8 o'clock in the morning, it's like, okay, that works.
Great.
Or 7:30, or if you're a surgeon, 6:30. The times keeps shrinking earlier and earlier for some of this, but the parents have been great about like, oh, give me as many people as you can on the call and we'll communicate with everything else.
So logistics of if we have a patient for referral, I'm assuming this is.
So
what
we
we're-
will be in e-records shortly, but really the paper referral is the best. And you
Okay.
don't need to give me the whole medical information. They've all got, everything is in e-record already. So all their subspecialties are there.
CE record.
So what's not always in the record is, do they have home nursing? Is there any other social considerations that, you know, like this, don't want to put into e-record? But if you can put that on the form, that makes it easy to say, yes, we agree.
And do we have electronic forms?
So if you go on the website, you can, us on a children's website and go into complex care, that form is right there to pull up.
So we'll make sure for all of you, we'll share this out with an electronic version. For you who are, those who are on the video call, you know, we'll send out with our minutes, the electronic link for that
Yep, and the brochure and everything.
and the brochure, yes.
I've got the email.
And we'll just put it into minute as a document, right?
Yeah, absolutely.
Yeah, maybe somebody could put.
Yeah, and then share it with the rest of us.
Are you pointing fingers here?
You're on it. Thank you, Liz.
Thank you, Liz. And then share.
Let's share. All right, good.
Can I say a couple of my favorite things about it? So I've had the privilege of doing this, working on ET6, and the hospital follow-ups, I think. Because again, with the discharge, like, you know, the patient's been in the hospital and they need to be seen tomorrow, and of course you don't have any spots open, and so we've done a lot of things for complex care. We'll see them tomorrow and then we'll get them in, you know, within 4 or 5 days. And complex care has been really great about communicating, like if they'll do an assessment and say, actually, you do need to be seen today. But to just have, a lot of the time they say you don't need to be seen today, which is so, so wonderful. And then I have one patient who's particularly ill on a ventilator, complex. Every time he sneezed, he got admitted to the ICU. And so they actually did, like just scheduled every other week visits for a while until it got to the point where, his parents understood more about, you know, how to triage different things and I mean, it saved him. It was a disaster every time he came in. And it's really, really helped.
And Grace said she really didn't come to Strong Pediatrics to do complex
I
care.
did not.
All right. Great. Any questions from anybody who's zooming into the meeting? Questions, comments? You guys okay up there? All right. Any other questions, comments from the team? Neil, this has been one of your dreams.
Yeah. I made it happen.
I wanted to take a moment and just thank, there's a number of people from HP who have helped with getting this going. Christy Howard has been a great champion, and the team, the informatics team that works with her. Adams has already been thinking about things and ways to be able to maybe support the team around some pharmacy issues if they arise, so and our care management team is going to be involved in this too, kind of watching, because often are the people that have helped you all, I think, with those complex referrals. And we recognize that Neil's talking about the top tier, the most highly technologically dependent kids, but there's that next tier down. And so one of the things we're hoping to work on with their team is, what are the workflows for that? Because you still may have a child that has 3 different specialists and a surgeon, but they don't hit the top tier. And so how can we do a better job around the care coordination with specialty and with surgery and primary care as well? So that's a work in progress, but we recognize it's a need. So more to come.
And there is a phlebotomy meeting that's been going on for 6 months about what can we bring in for a little bit more friendly phlebotomy at Strong especially for our developmentally disabled kids.
Yes.
So that is gonna be starting soon as well, with having set times where Child Life will be down in the lab and can schedule appointments to help with that initial phlebotomy. And the VAT team, vascular access team, there's some kids that like no one's even tried. They get done by the vascular access team. We'll have a way to schedule those so parents can come in on Thursday morning at a set time and not have to say, yeah, we'll get to you whenever we can get to you. Because if they make the mistake of coming on a Saturday morning, they're gonna be there for hours because there's only one vascular access person. So that'll be coming soon.
So we'll make sure that, a lot of that kind of messaging is going to start coming out to primary care docs through the office community practice, but we will elevate all of that messaging as well through HP. You might get it twice, but that's the kind of stuff that you guys want and need to receive. That's great. Thank you so much.
Sure.
That's awesome. Thank you. Moving on in the clinical agenda. I just want to check and see, did most people in the room receive the information that came out around RSV prophylaxis? Okay.
It was very good.
So,
Very helpful.
all right, good. I'm glad to hear that. I put them into slides in case anybody didn't get them. Is there anybody who didn't receive that or who wants just a very quick overview? I really wanted to see what questions people had and give an opportunity for you all to sort of share what you're doing a little bit if you wanted to, just open dialogue, but.
Well, one thing I will share is we had conversations with the manufacturer, and anything that expires is fully refundable.
Yes.
So.
Okay, you
that-
got a
that's good.
confirmation?
That-
I heard that, but I didn't want to put that in this thing
So
because
we
I thought
got
if I
that
was wrong.
directly, so that, because the hospital basically told us they weren't gonna be able to get it up and running
Yes.
this season, so we bought a lot, and then the hospital started giving it to everybody, so most of what we have expired somewhere between October and February of next season. So we may be able to use it then, but if the hospital's doing a good job, those low doses we probably
Right.
won't use, but they're completely refundable.
Okay. Janet, I know that had been one of your questions about refundability, so you got that, right? We were in that meeting together. Okay, good. Okay, so great. I think that one of the questions that has come up from the clinical teams with the children is, are there practices that may not be able to do this or be able to, respond for their kids? And is there need for any centralized type of coordination? And we've got time to plan for that. So I don't want to put anybody on the spot asking you what's your plan right now, but if it's all right with you, we're going to design a very simple survey. Just a couple of questions that we will send out and kind of highlight it to your sort of a lead representative from the practice clinician and your administrators, just so we can find that out and see if there is going to be any need for centralized work. It's Wendy Howe, who's one of the associate directors for nursing, who does a lot of the community nursing work, who organized the COVID vaccine centralized clinic that happened at the Children's Hospital and in the community. And, we recognize that not everyone is able to, to do this. And so we just want to make sure that people know we want to have a contingency plan for those kids and make sure that we're doing this in the most equitable fashion possible. So I think we can probably skip all the rest of my slides, which is awesome. All right.
Vaccinate any moms that we're delivering? Because every pre-med that I see, I ask them about RSV prophylaxis and they all look at me like I'm nuts. get a vaccine. Well, I got a tetanus boost. No,
Oh, for the moms?
yeah, for
Yes.
the moms.
So-
It depends how
Actually,
preemie
I
they are,
would
because they
back it
can't
up
get
a
it
little
until 34 to 36 weeks.
Right, and there's only a season, there's just. Sorry, right, no, go ahead, that's exactly right.
Sorry.
So the prenatal vaccine, there's very specific things around timing. And so this is the bullet on here. It's only administered between 32 to 36 weeks of pregnancy,
Okay.
and it's literally like, 32 weeks, 0 days through 36 weeks, 6 days. And they're only administering between September and the end of January. And so you have to be that gestation in that window of time. And so this is the issue is you have babies and you have pregnant people who fall outside of those windows because they're, all of that happens not in RSV season, and that's where we need to be.
Are the rural OBs doing this too or no?
They are, my understanding is they are, but uptake is different. We'll hear stories of, some of you told me like almost all of your pregnant or, birthing parents had received it. And then we're seeing uptake of like 20%, maybe 30%. So I think it's really, you back it up one more, I'm sorry,
You're fine.
told you didn't need to worry about this. It's about a third of birthing mothers and parents who consented to receive maternal RSV vaccination when you look at the entire population. But we're expecting those numbers will climb because now there's so much more information about it. And I think all of our clinical teams are used to talking about it. And then the only thing I just wanted to point out is most of the birthing hospitals in the region are going to be taking responsibility for administering the vaccine, but not all. So in your area, I believe that they are. And so, but just check with the hospital, if it's not on the list on here. FF Thompson apparently is considering doing this, and originally they weren't going to. Noise, I think, is not at this point. Katie Edwards is on here. But Katie, I don't know if you've heard anything different. But I think that there were some conversations. I think what the systems are trying to do is make arrangements with the practices surrounding them to assure that the babies will be able to get. And for Oak Orchard, for where you are, I do you know about the hospitals that are closest for you?
We get most of ours, typically Unity is the main one that we get.
And
most-
they,
Well, I've been seeing a lot of babies, but
yeah, that's great in that group. So it feels like a better coordinated effort. It was, I shouldn't use bad language, but it was one of those shows last season, and everybody was frustrated. Nobody expected there was gonna be, the lack of vaccine. Nobody expected it was, we were told we weren't gonna get vaccine, which is why, things came out and everybody then kind of scrambled, and then all of a sudden the vaccine arrived. That was just a lot of crazy. So thank you for your patience. Thank you for working together on this. And this is really important for our kids. So I think we'll do well as a community. Yeah.
I got this question last year. It was kind of like, just get whatever you can get, but I've had a couple of pregnant moms that were like, should I get the vaccine in pregnancy, or is it better to get the antibody after the baby's born? And I haven't seen any data or any recommendations on that.
I don't know if anybody has strong feelings, but sitting in these group meetings where OB is present and infectious disease, people are like, cool, vaccine. If you're in the right window, yeah,
Okay, good.
yep. So that's, and then we've got this if they don't. So that's my,
It's an easier sell.
so I think that's good. Any other questions on that?
I just have
Yeah.
after giving it last year, because for some reason our small practice got a lot of doses of it. I will say that we didn't give a lot of the smaller dose. So, just pre-planning for everybody, because the babies just got to 5 kilos so quickly. That like we would miss them.
Yeah.
To a certain extent sometimes. So just pre-planning and knowing that the hospitals are gonna be giving that dose for whoever's for ordering it for your practice.
That's good advice. And I think also just in light of this, that most of the babies that I think the practice teams are going to be responsible for are going to be bigger babies. So, yeah, that's great.
And there's just a note from Katie Edwards in the chat. I do not know about the upcoming season, but Noise was not administering it and Finger Lakes OBGYN was giving it, so.
Okay, Katie, that's great. And we're going to follow up with all of the teams and try to post some updates as we get closer, but just wanted you all to have that information as you were planning for your ordering. Thank you. So then just one other clinical thing we wanted to talk about, I want to talk a little bit about cervical cancer screening. And I mentioned this at the last meeting, that this is a measure that is falling in our quality metrics this year. It's very specific, quite honestly, on the Medicaid contract. I want to be straightforward about that on the Medicaid contract. And I think there is a role for our pediatric and family medicine teams in this. And so just wanted you to have a little bit of high level data. We did a look back with some help from Christy and her team. Just looking at what our performance was in 2023, had we been accountable for that measure? And if you look, you remember, I think I misspoke on this before, but you're looking at patients 24 through age 65, but there's a 3-year look back. So if someone gets their cervical cancer screening done at 21, 22, 23, it falls into that measure. If you look at the full AHP population, we're running at about 65%, which is not fantastic. If you look at Excellus Medicaid, it's about the same in that space. And then you look at the difference with Excellus Commercial. And, this is what happens with almost in terms of, I think, access. And, these are issues we're hoping to really work on over these next couple of years, with the inequities and the disparities there. But when you look at the HEDIS benchmarks, because remember, it's always the HEDIS benchmarks that we have to look at. It's not the actual percent, it's the percentiles. We're currently at less than the 25th percentile for this in the Medicaid space. And there are about 350 gaps in terms of people who have not had a cervical cancer screen. This is for the whole population. This is not just the young people. And a lot more to get up to the 90th percentile. So if you break this down by age, it was very interesting to look at it by age. The two populations that sort of stood out as doing worse than the rest of the population, still wasn't doing fabulous, is the 21 to 30-year-olds and then the 60 to 65-year-olds. So kind of two populations that sort of think that this probably doesn't apply to me so much. I don't know if it's that important, whatever. And so to you all, obviously, we're going to be working with the adult primary care teams as well. But we're bringing this to you all to sort of say, let's look at what happens as these kids age out. I know you're giving referrals for them to go to GYN, but I also know it's really hard to get patients into a GYN in any efficient fashion. So I just want to run past you after listening to you all, and some of you gave me feedback after the meeting last 2 months ago. This is what we're planning to do. The next slide.
Yeah, sure.
Yeah, here you go.
Anytime.
Thank you, Vanna. So we really want to kind of follow the theme of Cervical Cancer Awareness Month, which in 2024, which was Learn, Prevent, and Screen. And so I'm starting with prevent. So there's no question HPV vaccination is critical. You all know this. I'm not going to belabor the point. We do have the AHP resources that were developed under the Start by 9 campaign. And we will re-up those when we send out information from this meeting, just so you have them. There's patient information handouts. There's information for your practice teams. But just as a reminder, this is really, really important. And we sit on the percentiles, of performance are going up a little bit. We're struggling a little bit right now. We're still doing okay, but we're not killing it or kicking it out of the park. So it's something I think if everybody can look at their patient numbers, if they have questions, if they want any engagement from our team for help, just let us know. But to the point of getting patients in for their cervical cancer screen, we've started engagement with OBGYN practices. And on a really wonderful, fortuitous coincidence, it turns out that cervical cancer screening and addressing the gaps is a big priority for OBGYN this year across our community, which was awesome. That one didn't come from us, but it was very lovely where they were like, oh, we want to work on that too. So this is not rocket science at all, but we're basically going to try to develop a really good referral pathway. Very efficient referral pathway, confirmation from the OB practice teams that they can bring these patients in within 3 months or whatever their interval is, but you know what it is, and the patients would know what it is. Priority circle back for patients who don't make it in for those visits so that we close the loop.
There'd be letters.
A letter.
Exactly.
Oh,
Yeah.
whoa.
I know.
How do we know?
I know. Sounds like a crazy thing, but I.
Yep.
And
We can dream.
Yes, so a list of
Is that
OBs who
out?
take Medicaid, yes, so we're gonna, it's not done yet, it's in progress. I'm working with our team on this, but our hope is to push this out before the end of May. So that we still have a sufficient amount of time to really work on this, and that's really the first step that we really wanna start with. And there's a message.
Just a note from Laura Markwick at NP Family Care. She says, their rates of cervical cancer screening increased once they were bringing in an OBGYN NP once, 1 day a week. They have a high Medicaid managed care population, and they were far more agreeable to come to her office than go somewhere else for the PAP, so.
And Laura, yours is a family medicine, family practice, right? So that was a great solution on.
Yeah, I coach somebody. Cause they just don't go anywhere else. They only want to come here and we're still not where we should be, but we're a heck of a lot better than we were. And it's a win-win situation because I mean, I had to go through the credentialing and stuff, but which is a pain, but we did it. And it's a win-win situation because the practice that we got her from one day, they're getting referral source if she comes up with something that's beyond what she can do. So we were able to establish that relationship, but I hired her for 1 day a week per diem, and it's working out.
That's great. Laura, that's an approach that I think we'll share with others of our family medicine practices too. It makes a lot of sense in that space. So we're not asking you to lift the whole thing, but if we could make this better, it just makes sense. We're clearly missing the mark with these young adults, and not getting them in time. So I will be circulating as we develop this. I will be asking for you to review the referral pathway, make sure this makes sense, trial it. You know, I want to make sure it really works and you actually get letters or you get notification if they don't make it in, et cetera. And you get follow-up when they do. So you get the results. So great. All right. We are not doing care management updates because Robin McElligott was not able to join us. So that was for your 10 minutes where we all hung out and talked at the beginning. So we actually are pretty close to being on time. Yeah, that's me.
Okay.
Oh yeah, that was just
There was some extra stuff.
that was
so I
just
wanted to
in
make
case
sure.
somebody has a question later. So
Okay,
thank
sure.
you. So it's Jana is up as she's.
It is me, so bear with me while I change my screen. So we're gonna talk about things that you guys love talking about, and that is gonna be quality. And our reward plan for this year. So I really just wanted to kind of talk a little bit about how we're gonna be communicating about quality this year, because we do have some big transitions that we are very excited about with Health Catalyst coming down the pipeline. But that is gonna limit some of the stuff that we see consistently across the board. So in service of being equitable and treating everyone fairly, for quality, we are gonna change the way we're talking about it this year. So what that looks like, measure quality performance is gonna be based on Excelis lines of business only. We know that we're gonna have data coming in from that pathway. So we're gonna be looking at the Excelis population, Excelis thresholds for this year. Now, you all are probably like, but isn't that what we do? No, actually, we always take a population-based approach. So we are payer agnostic typically. And so when we look at your quality measures and your quality performance, we do that regardless of payer. So this year, because we do know that we're not going to have that clinical data coming directly from the EMR, it is going to be just Excelis patients. Okay. We are also going to be reporting. Did I do that right, Willie? Okay. Elizabeth was also supposed to be joining us today. Right, yeah, so I'm like, hey, if I didn't do it right, you let me know. But we will also be talking about performance at a network level. So again, because we're not gonna have clinical data coming in from every single practice this year at the same time, we wanna make sure that we're being fair in showing that data. So it's gonna be provided quarterly at a network level. You're gonna see how we're doing as an AHP whole, not necessarily how your practice is doing or another practice is doing. So that's how we're gonna be looking at that. We're gonna provide that by line of business. So you're gonna see it for Medicaid, you're gonna see it and commercial. And that is important because I just mentioned, we've got this Health Catalyst change coming in. We've got the rolling practices for, switching that that from Arcadia to Health Catalyst. So we want to make sure that we're being consistent. Like I just said, it's going to be quarterly frequency, and then where we're going to be putting that. You're going to get it in network news, you're going to get it in email communications, you're going to get it at adult and peds PCP meetings, practice managers meetings, because we want to make sure that however you're typically getting information from AHP, you're seeing this there as well. So if you have any questions or concerns about, oh, well, this quarter rolled by and I didn't see that, just let us know. It could be that it showed up in a place that you don't normally view it first. Elizabeth has also been so gracious to provide us Kevin Kelly as a dedicated resource around these communications. So if you do have something that you're wondering, oh, well, I saw that, well child 0 to 15, the performance for AHP isn't so hot, and I want to see what my practice is doing in that space. We will be able to do some independent one-to-one kind of communications there with Kevin Kelly. So if you have questions about your specific practice performance, you can always reach out. It's just very labor intensive to do that. So if we were going to do that report for every single practice, it would be sucking up a lot of time for this year. So in the interest of getting Health Catalyst right, we chose not to do that. Any questions about that before I move on? Okay.
So you're telling me the PER and all of that, we shouldn't be checking.
So I will talk about the PER
Sorry.
separately because that is it's a good question. But I will talk about that. We do have changes in what's going to be visualized in the PER as well for this year. I'll just skip ahead. That's fine.
Sorry.
So it's a good segue though into the PCP reward plan. So the next thing I was actually just going to talk about was the quality measures. Those haven't changed really in the pediatric space. Really the only difference there is that the well child 15 to 30 months is actually pay for performance this year. So it is going to be included in our Excelis contract. And so you'll have that we are going to be held accountable for. As you know, in previous years, and as we normally do, if we pick up a new measure like we did with 0 to 15 or 15 to 30, only so that we can get that preliminary data and figure out how we're doing across the network. So that's really the biggest change there in the pediatric space. What is staying the same? So I'm talking about a lot of changes. The thing that is staying the same is really the basic structure of the reward plan. Still quality, still cost performance, still citizenship, right? That is not changing. There are some changes to subcomponents. Some initiatives have shifted and moved where they are in the reward plan, but really that is not changing. The ability to see these components in the PER is also still going to be there. But again, because of where they've shifted from and to, it might look a little different. In the pediatric space, really we're talking about quality as 70%. So regardless of what we're doing is, if we hit quality and we earn gain sharing, every provider is getting a base amount. We've done this in the past when we've had issues with data, so you might not be unfamiliar with that. What is new is we are telling you that no. So you don't have to worry about it. We made that decision and we think it's the right thing to do. So that is how we're approaching quality. With that, citizenship is going to make up the 30%. And you're like, well, citizenship just really, that's not a lot of clinical stuff. This year it is for peds. So in citizenship, you might be familiar with that. That's available at the practice level or the provider level. So at the practice level, if you achieve 2 or more of these components, every provider that's PCP reward plan eligible gets that for the year. So that's an easy 30% win for every doctor in your or every APP as well. That's included in the reward plan in your practice. If it is not achieved at the practice level, which is very rare, there is an individual provider look-in. So what we'll do is say, oh, well, they didn't get it at the practice level. Have they achieved it at the provider level? This is what I'm saying, things have shifted a little bit. So in black are some of the things that have already been in our reward plan for citizenship. So if your practice manager attends 2 or more practice managers meetings in 2024, that counts. If the practice participates in a pilot or an administration. So collaborative care, trauma-informed primary care projects, and comprehensive developmental screening. Those are things that you're familiar with. We've talked about them before. And those are staying in for this year. Participation in those will check the box. But what we've done here is we've added a couple things. So depression screening and follow-up, no one shoot the messenger, okay? Everybody had feelings about that one. We have actually moved that out of as a separate initiative and pulled it into citizenship. We're still defining what that's gonna look like, but this year it's really sounding like it's gonna be more, if your practice is interested on working, in depression screening and follow-up, if you wanna have some discussions about workflow and best practices and EMR stuff, that is gonna check the box for depression screening and follow-up. Some of you may or may not have met our newest employee. Yeah, she's pretty new. Tanya Jo Nazra, who is gonna be working with Elizabeth in this space. So more to come on depression screening, but that is where it's gonna live for this year. And that is because we get that data, that's clinical data that comes in from the EMR. So going back to Health Catalyst, we're not gonna have that for everyone this year. Smart therapy education. Thank you, Bob Adams and Paul Tremblay, who is not here today, but Bob has been doing rounds with some of the practices who are interested in smart therapy. And that is going really well. So in any of that training, if you attended clinical grand rounds and listened to that presentation, you're getting citizenship credit for smart therapy. And then geriatric support care, you're not geriatricians, but it's in there for 2024. And then what we've also added here is other identified initiatives. So we had a conversation and said, well, if something launches in June, you should still get credit for doing it, even just because we didn't know about it in February. That doesn't change how we should approach that. So we've added that in as well. If you are participating in an initiative that we think would fall under that bucket, you and your practice would know about it. And then the other thing that we have down here is relative to Health Catalyst. And this is a big one. I've said it like 4 times now, but we want to make sure that we're doing this right. So we're looking to you, our partners in this space, to kind of help us along the way. So we have been chugging along. Some of your practices are already in the, battery's gonna die. Some of the practices are already moving along and starting to get those connections. But what we are really looking for is any practice that's slated to be implemented in this year, timely response. If Willie sends a communication, Health Catalyst sends a communication, just get back to us within a reasonable time. So maybe less than 14 days as opposed to 30. Limit some of those follow-ups that might be needed. Thank you.
You're welcome.
And there is going to be an element of data validation, which we are defining now and moving into. So Willie is also going to be helping us there.
Everyone's
Okay.
getting on this.
I'm so sorry. I was like very
I was
convinced, but
working
then
through it. I was working through it until me popped up.
I
Thank
did
you.
not realize. I was just thinking you're gonna lose everybody, right?
Yeah.
You're running the
Yeah.
Zoom. Yeah, okay.
But we had time though. I would have gotten there.
Okay.
But yeah, so there's gonna be data validation where we're gonna be looking, our team is gonna be working with your teams to make sure that what we're pulling into Health Catalyst is, and we're doing this whole thing because we know that we had data validation issues. And so we want to make sure that we're doing that right. For those practices who are not slated to be implemented in 2024, for which there are not many, what we're really looking at is participation in any discussions that we might have around Health Catalyst, any education seminars, anything that we find, oh, this is a learning opportunity for how we're going to use the new system and that we engage with the practices on. That's how you would get the credit for that if you're a practice that's slated for later implementation. Willie and I just met last week, and so I've got a timeline for all of those. If you have a specific question about whether your practice is slated for 2024 or 2025, reach out, and we can definitely help you with that information. Any questions on this slide before I move to provider level? At the individual level, again, same kind of theory here. If it's black, it's pretty much staying the same from last year, and anything in blue is new. The first one, more AHP information sessions, this would account for that. But really, this used to just be attending clinical grand rounds. And we know that's a hard one for one time a year. So giving some more opportunities for the engagement that you guys do have with us, because we talk to you a lot. So we want to make sure that you're able to get credit for those as well. Similar to the initiatives that we identify throughout the year, if there is an information session that would count, we'll make sure that that's noted on whatever invite or follow-up we send. Provider completes an average of 20% of targeted Vatican visits. This again does not apply to you because you're in pediatrics and it is not currently offered to pediatricians, but it's up there because it is part of the reward plan. And so if you log into the PER, you would see it there.
Can I ask what the PER is?
Yes.
Provider engagement.
Thank you.
Yeah. So the provider engagement report.
It's gotta come up, you know.
And I apologize, because I should have pulled up slides, but the provider engagement report is really, I call it a 2-year initiative just because I've been here for 2 years and we've been working on it for 2 years. And it is to really show the holistic performance to our PCP plan. For those of you, which is everyone in this room who have been around for a while, you know that we used to do just quality as, you know, part of our provider incentive. When we made the switch to multiple components, you know, other initiatives, we wanted to offer you more alignment into how our contracts are structured for performance, right? There is quality, there is cost, and there's also that element of improved care, best practice. And so when we did that, that still left us limited in what we could show you in Arcadia. That is a place for where measures live, right? And so we wanted to make sure that if we're gonna say, hey, your citizenship, you get credit for that. Well, how do I know if I've done that? So we developed the PER to kind of give you that holistic review of your PCP report.
And where is that living?
It is living online. We can get you set up. Let me make a note here.
Can I ask, we've started to see one of our NPs show up on our
Yes.
reports,
Yes.
which we were unfamiliar with. So I was curious what's going on with that.
Yes, so there's a couple. I'm gonna stop sharing my screen so people don't have to look at these slides because I'm done with them.
Before you do,
Yes,
accepting new patients at the time.
yes. So at the time that we calculate the reward, we want to make sure that we have that information, which is why it's important to keep it accurate. If you're changing your panel, you guys never really close your panels. So that's not usually an issue for pediatricians, but when we do the calculation, we want to know.
Where is that documented? Like what time, like,
We get that information from the practice. So if you're, I believe we have that your panel is open.
It's more likely for adult,
Yeah,
for adult
More-
purposes.
I mean, that's
Where
one of
they
my
close.
struggles right now is 2 of the other pediatricians in the region and the area
Mm.
are gone now. And I am full to bursting
yeah.
and I've had to say, no, I can't.
Mhm.
So
Okay.
how does that?
Are you still accepting newborns though?
Oh, yes.
So you're still accepting patients? Right.
Okay, I
Yeah,
get you.
yeah.
Okay,
It's if you close down and are not accepting any
Okay.
patients.
Patients,
Yeah.
that's,
okay.
yeah.
We've had some grand debates
Mm.
about what is legal and what is not
Mm.
an issue, because we have lost 4 providers and 2 nurse practitioners in the past 12 months.
Oh,
So we are in full circle the wagon mode. And so for us, transfers are really tough right now.
Yeah.
And we've had a great deal of turnover, so we're just trying to take care of the people we have.
Sure.
But what I have been told is either you say you'll take anybody or you'll take nobody. And if you take nobody, you can't take the second baby of a family that's already, and that officially by the rules of Blue Cross Blue Shield, that is the way it can be done.
Because oftentimes they'll just call the office and say, are you accepting new patients without
they do that.
identifying them?
And they will test you out to see whether you're. And so we've really struggled with that. You know, I agree that, you know, the cherry picking thing is not great, and, you know, that everyone who's enrolled in a healthcare plan should have access to, you know, to a doctor. That totally makes sense. But at the same point in time, it doesn't allow for making decisions about how many patients you can take care of
Or
as
what
a
age
practice.
range
As a practice.
it is reasonable.
Right,
Yeah,
you know,
gotcha.
and that, that's been a debate for probably 10, 15 years, going back and forth, and who is it that we can, who can we find, who can give us like a definitive? Cause my billing manager is never gonna believe it unless it like has. a
My billing
stamp.
manager and your billing manager are in cahoots, because she has the same feeling. Very strongly about it.
Yeah, that.
So don't know the answer, but we can certainly explore that. Yeah,
Okay.
yeah,
You
let
know,
us see what we
the
can
thing
find
is,
out.
like,
A
can you
couple of
take
different
the horns,
resources.
you know, of current patients, families,
Yeah.
established families, you know, but say you are not accepting outside of that, new families, new transfers, those kinds of things.
Thank you for raising it. Thank you for raising it even further, and we will get back to you on that. Okay.
Okay. Can change your screen
And
now.
why is that a quality measure?
Thank you.
It's not a quality measure, so.
I mean, a citizenship, why
So-
doesn't that make me a better
So
citizen?
part.
You're a team player.
You're a team.
No, I'm
So-
sorry.
So part of citizenship is really just getting back to, you know, that affinity with AHP, establishing some things that say, we're here, we're trying to do well by the network, trying to do well by the people that we serve. AHP is interesting because we have two sides of our contract. So we do value-based care, but we also have free contracted health plans. And so part of doing well by those plans is making sure that their patients have access to, you know, to providers. And so if every provider in our network, and I am sorry because I do recognize that, especially in primary care, you guys. But if everyone decided to shut down their panels, there would be nowhere for anyone to go. And we're
That's
running
gonna
up.
be a bill in pediatrics
Yeah.
because they can't find an adult doctor.
Right.
And we are running up against that, so, you know, I recognize it's a hard.
Why we
thing
can't
to
let them
strap.
go.
Quick question, I don't know if the group in general, at what age, do you have an upper age limit in terms of malpractice or where you have to let go of your patients? Because the internists won't take them. I mean, they won't, they're phone.
Well, and
Any comment?
our 22-year-olds drive their heel.
Yeah.
But by 25, 26,
So from experience and discussions with my insurer, which is
Yes.
PRI, there's no upper
that's what I was
age limit.
told.
But don't you have NPs that are PNPs, if they're pediatric nurse practitioners, they can't go beyond a certain age.
So I think the big
You have
thing is your
family nurse
insurance.
practitioners, they can't.
My
I think it's 23.
insurance covers me to see any age. I just had a 30-year-old
Okay,
disabled
yes,
patient.
especially when they're, yeah, okay, thank you.
And so we were checking. They were 30, but our insurance said any age.
Yeah, but some of the insurance companies won't pay for annual physical exams beyond 21. So we've gotten a few of those patients that are, just keep coming and they have other issues and they're still with us. And then you do a physical exam and realize
You wanna go your
can't bill for it.
What
So
insurance?
that I'd have to check now.
Now
and
I
it
wanna
was
go back
it.
and check.
Well, and it just denied as physical exam. So then, you know, the billing person comes back and says, well, can you put it under something else? And then it just gets resubmitted under probably a 99214 for anxiety, depression, or, you know, or whatever the.
I'll check, you know,
Well,
does that
I
even
mean,
matter at that age?
usually I sort of take care of all that at a well child.
Yeah.
Or a adolescent or
Right.
adult check, but you also cover so much else that's
Stuff.
important. and
Exactly.
Get into your OB and do all of these other things if you're still with me.
Absolutely.
So, but that's also can be an issue.
Okay, good to know.
Janet, I'll let you know on Health Catalyst implementation. So that's about that. Back to your question though, Liz, about APPs. We started a few years ago, actually, when New York State changed the your NPs and PAs at the practice. Cause yeah.
I totally forgot we started there.
No, I was just trying to, because we have two family NPs and we have two PNPs.
Or why they're showing up on your report, I think was your
Yes,
question.
Was your.
What does?
Advanced practice
Oh, my Metro.
So. Some people, some people still call them mid-levels, but APPs is the preferred terminology, I think. So when New York State allowed NPs to go full practice, that changed how patients were attributing, right? So for some practices, they might let their NPs panel patients, they might have them seeing them for annual well visits, those types of things. So to ensure that your practice was still getting attribution for the patients that your practice was still caring for, we started to enroll APPs into AHP. So that's why you're seeing them pull up in your reporting, because it's showing on our reporting from our payers that they have attribution under their NPF.
So is that basically your functional PCP versus your assigned PCP? Is that kind of the deal?
Yes, that's
Okay,
exactly right.
gotcha.
Yes. We've gotten that question from a couple people too, so that is what's happening. And that's really because otherwise the CI that we pay for attribution falls away, if we don't enroll the APPs. As well. Clinical integration dollars, and then as quality, so those, I'm just throwing all the letters out there. And so it does, and it is a good question to ask though, because some people have wondered what that does for a reward plan. If we've gotten these people, these APPs who are now included in reward plans, what does that do for how your practice decides to share that incentive or not share that incentive? How we engage with your APPs on quality performance and how we communicate with them. And so that is something that, if you guys have questions, concerns about, you can let us know. Really, our rule of thumb is we provide the money to the practice. What you do with it beyond that is and I know that's a difficult conversation, especially for practices who traditionally pass on the full amount to their providers who are included. So if you have any questions, just reach out, we can chat through it. That's my spiel for the night.
Very good. Good. Thank you.
Okay.
Christy, do you have any one-liner about Health Catalyst? There's a lot of excitement and enthusiasm. There's a lot of work, but there's a lot of promise in this, right? I just want for people, if you want to say.
One line. Well, a couple. We're 6 months into a 2-year implementation. We're doing a lot of work right now, bringing on practices. We've got all of our health plan, MVP and Excelis data loaded and into production. So huge effort, that's done. Now we're focusing on the EMRs and the clinical data from the practices. Designing the dashboards and the quality that you'll get to see more at future meetings. The experience isn't completely different than what we've experienced with Arcadia. Really pleased we've made the decision, and we just really look forward to being done and you all reaping the benefits from some of this work that we're doing.
So it's a lot of work, but it's very hopeful. So I wanted you to hear that because,
It will accurately measure what you're doing in your practice and it will not be so hard on you all.
yes.
So is Arcadia, that's going by the wayside? No.
Bye-bye.
Yep, it will be, yes, we will be ending the contract in 2024, likely near the end of May.
Oh, gosh, real soon. Okay.
That's why we're in here.
That's why
transition,
that's
where we
the
won't have
transition.
all these because it's gonna turn it off for PCMH from it.
So let's talk about this. It's a nice segue.
Yeah, let's talk about it.
She was just saying she used to pull reports for PCMH out of Arcadia, out of that stuff. So the last thing we wanted to just cover and for this, I wanted to just talk for a moment about primary care supports, practice supports, and connecting to Medicaid enhancements. There's because the state budget is still not final, or if it maybe it's final now, but it wasn't an hour and a half ago. This is what we know. It's not a happy budget. I'm just gonna say, except there's a lot of good things in it for kids. So it does look, I don't want to jinx us, but it looks like some really positive things are coming through, and some very positive things are coming through because of the waiver. And we've talked before about the waiver amendment, the $7 billion that's coming, and there is still an incredibly strong focus. Waiver is basically a disbursement of dollars that comes from the federal government to states. They apply to do what's called a demonstration project, to say, we could use these billions of dollars, Medicaid dollars, and actually demonstrate improvement in care. And we could change the way that Medicaid actually reimburses. That's waiver. We never got to the value-based payment changes, but there were a lot of nice initiatives that came. Ours was one of the only regions in the country that actually, or in the state that actually focused on kids and on pregnant people. But now it's required in this waiver. And so children under the age of 6, children over the age of 6 with at least one qualifying medical condition, which is everything, mental health, obesity, you name it. So most of our kids will qualify. The waiver is focused on equity. So a lot of this is around social determinants of health, social drivers of health, and actually trying to move to a model where Medicaid will actually pay for some of those things, for food, for transportation, for housing. Yeah. So it's a demonstration. So there's a lot of projects that will sort of launch out of this, but we're in a nice place in our community to do that. And then the other things that were really exciting about the waiver, if it all comes through, is that continuous coverage on Medicaid for children 0 to 6. So stay tuned. Once it's out a summary, kind of like what we just did with Nursivimab, we'll send something out that'll come from the Office of Community Practice. We're working with the AAP on that because they're right in the thick of all of it in terms of advocacy. And then we'll also send it from our teams. But the thing we know about increased reimbursements in Medicaid that would be applicable to primary care providers is they're going to come in the form of PCMH dollars. Almost everything in that bucket is going to be linked to PCMH. So we are looking at a variety of different ways to support you all in PCMH. I have to ask you to stay tuned on that because there may even be some dollars coming in the waiver that could be coming towards technical support for practices. We've asked for that, but we have to see. But in the meantime, our very lovely teams here have said they really want to do what Mary Beth Robinson suggested, like, I don't know, 5, 6 years ago when we sat around this table, and do a crosswalk between PCMH and what we're doing here so that we really help you leverage the work that you're doing with AHP on the quality measures and use that towards your PCMH. So our teams are going to work on that and work with you, and especially think with reporting. You would have pulled through Arcadia. I saw the look on your face. Your eyes got really big, Jen. It's a moment of panic. So we're going to work with you on that. And I'm just going to say, stay tuned, more to come. We're also looking at, do you want to talk about the other things that we're looking at in terms of support for practices in general? No, you don't want to?
I want you to.
Oh, I
Take it.
I wanted to give you space.
No.
So we are looking at vendors. Some of the practices already use vendors who do pricing comparison, around medical supplies, around actual drug and vaccines and things like that. We're looking at some of those and vetting them to see if there are any that we would recommend to you that could enhance the work and cut down on the work of your teams, your nurse managers, your administrative teams or some of you actually who are doing that kind of trying to get the best deal. I don't know, Bob, if you want to say anything about that.
Yeah, it's like Penny Horning is, she sent me a list of her vaccines and the costs that she's paying. Melwood, and so if other practices are not quite sure, am I really getting the best deal? Because you should be getting the kind of contract pricing that the university is able to get, like GPOs and things like that. So, but the proof's in the pudding. So I'm happy to help vet that with you, and kind of if you send me your what you're ordering and what your prices are, I can go back and make sure it is right. That pricing is coming through to your end, and somehow something didn't miss by the vendor when they're setting it up for you. So. And that's also, I'm working with Jane on that stuff too.
And, I will say this, that was one of the things that came out of, a lot of you joined us in the fall to have some conversations, around what we could do to help. And that was a big ask. A lot of people were spending a lot of time price shopping for the things that we need to run our practice. So we're trying to be responsive and find some opportunities there, so.
Are you talking about like vaccines or?
vaccines, medical supplies, anything that you might purchase. We are thinking about it and looking at some options that we might be able to bring to you, so.
Yeah, and getting it from your end too, though, instead of just sort of like, this is what's available. We look on the catalogs, we'll see the pricing, but you know, what you're actually seeing come through is,
Yeah.
you know, charges for you. We can at least have that information compare it to what it should be, make sure it's, you know, it is truly the best deal that we could get you or whatever, stuff like that.
If on like vaccine shop, it shows me that I'm an AHP automatically, do I need to double check that price or no?
You should be, but that's kind of what we're starting, is like, we're just doing some fact finding, double
Okay,
checking, making
yeah.
sure. You would hope that that's the case, right?
Right.
So
We want to
that-
validate that that's the
Okay, I can't do it anymore.
I know. So send some things our way. Let us take a look and see. Questions or anything you want to talk about? Thank you for coming in person. Thank you for joining by Zoom for those up there. And I want a show of hands. 2 months from now in June is meeting. Do you all want in person or do you want remote?
In person.
In person. The room says in person. All right. Sorry, you're remote hangers. I hope you can have in person for the next. Thanks, everybody in here, but once you get here.
These are PCRs, reimbursement. We're not